Hi everyone, and welcome to the latest episode of Knott's Farmcast. And it's our box set, second in a box set, where we're looking at DMS. And today we have two very special guests with us, because we're going to be looking at DMS from a trust perspective. We have the lovely Lauren Docksey, who is Chief Pharmacist at UHDB, and the equally lovely Stacey Saddler who's a pharmacist with NUH, and has worked with our other guest, who is still a pharmacist and is still our services implementation manager. That's Mike Jones. So welcome everybody. And I think if I can just hand over to both Stacey and Lauren, just to give us a little quick introduction to yourselves and what it is you actually do within the trust. So Stacey, if I can start with you, because you're sitting underneath me in this podcast.
Hi, my name's Stacey Saddler. Thank you very much for inviting me along. I work at NUH and I'm a specialist pharmacist in quality improvement. So I spend a lot of time working with staff in the pharmacy department to improve things. And one of my roles is working with DMS, and I've worked with Mike for a number of years now to try and sort of optimize the process of DMS. I also do a little bit of clinical work, so I see it from kind of a clinical pharmacist side too.
Fantastic. Thank you, Stacey. And Lauren.
Yep. Hi, everybody. So I'm Lauren Docksey. Kirsten, I think you gave me a bit of a promotion there. I'm a chief pharmacy technician for medicines optimization at UHDB, so University Hospitals of Derby and Burton. And my post is assisting in the delivery of pharmacy and trust-wide projects. I currently manage the discharge medicine service, and after implementing it and embedding it into 2023, and I also dabble a bit with greener NHS projects, help with the delivery of the pharmacy and medicines management work stream, and more recently I support in the management of the Trust's prescribing concerns portal, which links in quite nicely to DMS actually.
It does, doesn't it? I'm not quite sure when you two have any time to sleep by the sound of that. All the things you're doing are fantastic. So two extremely knowledgeable people on this subject, and it's a real pleasure to have you. So I think if I can switch backwards and forwards, and I know Mike will chip in where he needs to, but I'll go back to you again, Stacey. Can you just talk to me, or perhaps you want to talk together about why DMS is so important to your team, to you and your team, and obviously to patients? What is it about DMS that's so important?
Well, I suppose I would like to say, I guess when patients are in a hospital, and if you've been a patient yourself, it's a really stressful, often confusing, slightly unsettling time. You're seeing lots and lots of different healthcare professionals. The pharmacy team is just, a small element of that. And obviously changes to medication is not uncommon. And whilst the pharmacy team will endeavour within a trust to speak to patients and try and answer any of their questions around sort of medication and their medication changes, it's not uncommon, and it's to be expected that people will forget that kind of information.
Absolutely.
Often won't think of questions because we often don't at the time because we're in a really stressful environment.
You want to escape, Stacey, don't you? I think
you do. I don't know whether Lauren, you would agree with me on that.
Yeah, definitely. I feel quite passionate about DMS actually. Obviously, as I do, it's my day job. But I agree, Stacey. I think it's quite an overwhelming time, isn't it, to be in hospital, and quite a lot of information to take on board around your condition, any procedures that have happened, and then remember your medication changes or any potential side effects and things. So I think from a patient's perspective, it's good to know that you've got that bit of a support reach out point for when you're discharged from hospital.
Yes.
And I think from like a pharmacy trust point of view, we know that following discharge, medicine related problems and communication around changes on discharge is quite common. So it's really, I feel that DMS is really important for preventing that confusion for patients, preventing harm, and also potentially readmissions as well.
Yes, absolutely.
Yeah, I mean it makes the discharge process a smoother process. It's a process that is there for every single patient. There's no postcode lottery. It's a service that every patient should get, and it's another safety net, really.
Yes.
And patients, when patients get back to their sort of usual environment, it's an opportunity for them to have a chat with the pharmacy, a community pharmacy team that they're probably much more familiar with. They know, they deal with their medicines, week in, week out.
Yes.
It's an opportunity for patients to kind of ask questions, raise issues, and obviously, the community pharmacy team are there. They're like the early warning system. They can see if there's compliance problems. They can see if patients are not following what they should be doing or are having issues, and it's invaluable, really. And obviously NHS, Derbyshire, they're really busy trusts. So if we can avoid any readmissions with that are avoidable, then that's only a good thing, because it will help patient flow. It has a financial benefit. It reduces patient harm. I think there's evidence to say even if patients do get readmitted, if they've had a DMS, their length of stay is shortened.
Shorter, yeah.
Yeah, so I mean, there just doesn't seem to be any negatives in my in my
definitely
viewpoint.
not, Stacey. Definitely not. Mike, have you got anything to add there?
Well, I mean, I agree literally with everything that Lauren and Stacey have said. I think,
yes.
I think for me as well, the importance of DMS has been growing over the past few years, but I think it will become even more important as we go into integrated neighbourhood teams, because one of the things that the neighbourhood teams are starting to understand is, certainly with the frailty agenda, is that the patients that they are seeing in a very particular way are the patients that pharmacists are dispensing their medicines to. And so the discharge medicine service for me is the only service that links primary care with secondary care all the way through. And I there is the other community pharmacy services don't do that, because they don't link into secondary care. So I think it's just a great example of where we collaborate together in this way and do it well. Not only are patients spending less time in hospital, as Stacey just said, there is less chance of them being readmitted to hospital because of medicine inaccuracies or compliance. And it's joining three sets of professionals together who are all interested in patient-centered care. So I can't understate the importance of this conversation specifically for the future.
Absolutely. And I think the three of you there have outlined perfectly what happens when DMS works well. Do either of you have, and I'm looking at Lauren and Stacey here, any examples of what happens when it doesn't work very well?
So I've recently actually, mainly today actually.
Oh, okay. That's very recent.
Just to reinforce what I'd already thought about.
Yes.
And it's more of an issue from the trust actually going out to community pharmacists.
Okay.
So it's kind of just to let community pharmacists know that we are aware of sort of when it doesn't quite work and the impact it probably has on our community pharmacy peers. So we found on a few occasions recently that patients that are having readmissions, if they have a DMS on one admission and then there's a DMS missed on that second admission, or vice versa, it can become quite confusing for community pharmacists to keep track of those changes and what's actually current. So that's something that, well, I'm trying to, a bit like we've discussed earlier, trying to kind of reignite DMS a little bit in our trust. We're quite successful at it at UHDB, but I think we just need to kind of get the fire for it again.
Sure. Yeah.
And I think that's why we sometimes we miss some of the kind of critical DMSs, really, particularly for those patients that are having frequent admissions. They're quite important to capture. So that's one of the things where I feel like we could do some improvement.
Okay.
And yeah, sorry, Stacey, I'll let you come in there.
Oh no, I mean we had a case study from a while ago where this is more of a clinical thing. So firstly, I would absolutely agree with Lauren. If you've got patients that do end up being readmitted very, very quickly, then sometimes the DMS process doesn't get done, and it is quite confusing then. And I don't think that's anyone's fault, but that is something that we probably do need to try and make a bit slicker.
Yes.
But yeah, we did have a case study a little while ago actually where a patient didn't get a DMS, and I'll be absolutely honest, I don't know whether they didn't get a referral or whether the referral wasn't done, but it was a patient had been discharged with a treatment dose of enoxaparin for bilateral PEs, so they had a clot in their lungs, and the plan was to change to rivaroxaban, and they were being weaned off carbamazepine, so there's another drug. So it was a very complex patient, so absolutely ideal for a DMS referral.
Yes.
The patient was actually readmitted, and actually what had happened was they did get prescribed their rivaroxaban, but it was a really low dose. It was a dose that was an incorrect dose. And I think it was felt actually if the information had gone via DMS, that would have been identified much earlier by the community pharmacist that was the wrong dose. They weren't given a treatment dose. The prescription could have been altered. As it was, the patient actually ended up coming back into hospital with a potential. They didn't know whether they'd had another reoccurrence of their PE. So, you know, there can be really big consequences if medication isn't prescribed correctly, as we all know, and it does happen. You know, humans do make errors, but it's the more people in the chain can hopefully identify that. So yeah, that was an example that we found that we thought actually if a DMS had been done, that probably would have been an avoidable readmission.
Fantastic. That's really, really interesting to hear that from both of you, and something certainly for consideration. I know Mike's just popped back up again.
Yeah, well, I was just going to say it just underlines the importance of the community pharmacist's role, working with the trust team to make sure, well, not just the trust team, it's the surgery team to get it right for a patient, because Stacey said, you're dealing with potentially really tricky polypharmacy issues, which need some thought, and those patients do need help to really understand why they're taking that medication, why it's changed, all of those things which may be confusing when they walk into the pharmacy, but they should be less confused when they walk out.
Yeah, absolutely. And that brings us very, very nicely round to a question to again both Lauren and Stacey, please. What would be your asks of community pharmacy? What are things that we can do better? Are there any areas where you want a little bit more help or a bit more insight? Can I ask both of you that? Maybe start with Lauren.
Yeah. So we look at our data from Pharm Outcomes every month. We pull the data. So we can see when some of the referrals are kind of sitting in as referred or just accepted.
Right, that's good. We're watching. Yes.
Yeah, I mean, I don't mean to sound like the DMS police. We're not really. But so I think I'd just like to ask community pharmacists. I know that they are it's a big ask on our community pharmacies, and they are asked to do a lot of additional services. But if they could look at those critical referrals more promptly, just particularly those with the high risk meds, just to support the safety after discharge, really. And the other thing is, I would just like to encourage community pharmacists to get in touch with us if they've got any queries at all on a DMS. If anything is unclear, we appreciate that referrals aren't always that clear. They don't always provide information as well as they could, for example, why a medication has stopped. So we welcome those questions. We're more than happy to answer them, because it allows us as well to review the DMS process, and look at kind of the bigger picture, how prescribing and things is done as well, and how that all links into our communication through discharge letters as well. So yeah, we're more than happy to receive queries.
That's really helpful, Lauren. I've just scribbled some notes down as you were talking then, and I'll put those as some bullet points. And I'm sure I can see Stacey nodding. You guys can't, because this is a podcast. So Stacey, I'm sure there's a few things you might want to add there, but you're definitely nodding in agreement to what Lauren said.
Absolutely. I mean, I suppose obviously Lauren and I do a lot with DMS, so we probably know more about DMS than perhaps some of our pharmacy colleagues. I think there perhaps is a little bit of a thought process that if I've done a DMS referral, it's going to get action. So and despite, obviously we do spend time saying, you must make it very clear to people and what have you. So there's but I would, like Lauren said, we would really welcome feedback from community pharmacists about things that, if they've received referrals, maybe reasons that they couldn't do them, things that could be improved. And actually, I think it would be really also great if we could have examples where they feel that they've made a really good intervention, because I think actually having examples of where you've done a DMS referral and potentially stopped a readmission is a very powerful, powerful message, because unfortunately we do live in a world where we're always very quick to say, well, this went wrong, but actually we should also celebrate what went right.
Agreed.
And all of that feedback makes us able to then look at our processes in-house and to make that, try and improve, because at the end of the day, the patient's at the end is the important thing in this, so we all need to work together to make the process as smooth as possible.
Exactly. And I think you've both answered the question there about why it is, and you mentioned pharma outcomes, Lauren, why it is so important for pharmacists to action and complete on pharma outcomes. Anything, and sorry, Lauren, I interrupted you there. Were you going to add something?
No, I was just going to echo what Stacey said about if we could get some like a positive feedback, where a referral has gone well. I try and do an update to our teams each month. And I like to share the kind of good news stories, just to help motivate the teams, really. So it would be really helpful.
I'm sure at least somebody listening, or at least one of our committee members, or somebody that we have a good relationship with contract, and we've got great relationships, we'll be able to get some of that information for you, definitely, because excuse me, we wholeheartedly agree. We've got to celebrate the good stuff, the positive, because that does motivate and inspire, as you say, Lauren, to others to do the same. So anything to add there, Mike?
Yes, and I'm going to sound very much like a broken record, and I make no apologies for this, because everybody listening knows what an essential service is, and DMS is an essential service. In other words, nobody can opt out. It is part of the contract. Lauren talked about, can you get on top of the more clinic, what's the word I'm looking for? The drugs that could cause a bigger impact on somebody first. And the fact is that each DMS should be dealt with in 72 hours anyway. That's part of that. If we can do it faster, great. But, you know, I think a lot of this comes down to process, lack of taking responsibility, lack of planning, and apathy. And I put apathy there first, because last, because there are so many of our pharmacists who are doing a really, really good job with discharge medicine service. There are a few who are not. And then, yes, there is a cohort in the middle. Process, how are you managing the process from the moment you get the referral to the moment that that patient goes away following a consultation with the pharmacist? Bearing in mind, you don't need to use a pharmacist. A pharmacist doesn't have to be involved in each part of the 3-stage process. I think that's important to remember. How are you tracking where you are with each of the 3 conversations? Because as we know, there is a reward for each, the first part, second part, and the third part. And I think the other thing which is causing problems in other services is not really understanding that every single day Pharm Outcomes does need to be accessed, as well as NHS Mail, because if a Pharm Outcomes referral goes down, or you can't do a DMS referral from the hospital, it can go by NHS Mail. So there are still 2 options we do need to be checking every single day in case we miss it, because the repercussions for somebody that misses it could be quite severe, quite frankly, because not knowing it's there is not an excuse. So there is a professional and clinical aspect to that. There is a process issue to that. There is a teamwork element to that. And the reason I bring up the Pharm Outcomes is there's been a real issue with Pharm Outcomes of late, certainly at the pharmacy end, actually going down, and information not being passed back to a GP surgery. So we have to be all over that. It is an administrative task. DMS is an administrative task, but there is the bigger element is the clinical element to keep patients safe. So, and last but not least, we get trained as pharmacists to do this work. There is nobody else in the healthcare chain that does. And not only that, we are getting paid for doing work that we are trained to do. And so it amazes me when the 3 steps aren't completed, or for whatever reason aren't completed, but they're not started.
Yeah.
Especially given the financial issues that community pharmacy is facing at the minute. Yeah. So I'll get off my soapbox now.
You climb down. No, that absolutely, Mike, and I think we touched on a lot of those things in the first episode of this series. You know, it is an essential service, as Mike said, and you get paid for it. And ultimately, it's all about patient safety, patient experience, and that's why we're all here. Doesn't matter what element of the system we're in. We're here to deliver, you know, an outstanding patient experience for everybody. So,
could I just
yes, of course, Lauren. Please.
Just following that, I mean, our completion rates for Derbyshire and Staffordshire are actually over 80%. So
Brilliant.
You know, we're doing quite well. So thank you to all the community pharmacists that are actioning the referrals.
That's great to hear. Thank you. I don't know whether Stacey dare tell us what it is for Nottinghamshire. I'm hoping it's around the same figure.
It's not quite as high, but we have really great pockets of community pharmacists that are doing incredibly well and are doing an amazing service. So again, I'd like to say thank you. I'd also just say, when we've done some dives into why things are done, we have got pharmacies that are doing the DMS process, but are not claiming for it, which again, you're losing money. But actually, you know, when we're looking at this data every month, and obviously when you're in hospital, the data you get is around completion rates. So it doesn't really matter from an NUH point of view. We can up our referral rates, but actually if we are not completing the DMS, it makes no difference to the overall things. But it actually makes it quite hard then if people aren't claiming for stuff, because it almost masks then the real pockets where there are problems, you know, the pharmacies that we need to work with to understand what barriers they've got that are stopping them to do a DMS and completing a DMS. So I would just say, yeah, if you're doing the work, and I believe the process has got a little bit better. So I do apologise if it's still very faffy, but it seems a shame that you're doing it. It's not being recorded and you're not getting paid for it. So it just doesn't seem a win-win on any level.
No, you're absolutely right, Stacey. Yes, please claim, absolutely. And I think you've both offered, you know, if there is feedback from any of the pharmacists or pharmacy teams, please let Stacey and Lauren know, and let's implement this collaborative working. And if there's anybody that's listening and they are struggling, you know, to complete for whatever reason, let us know and let's see if we can help you. You know, working together, you know, with Mike, obviously with his pharmacist head on and his services head on, together we can solve those problems, I'm certain, and we can get to, you know, 100% being completed, hopefully in the not too distant future. Because as I said, Mike said, it's an essential service. We've got to be doing this. You're trained to do it. You know, we're the only people that can do it. So let's crack on with it. I think we've discussed loads today and all extremely useful. I hope everyone would agree. So I'm just going to go around to my three guests and ask if there was anything else they would like to add before we sign off.
I just had a thought about just an example of this meeting, really, this podcast. So just the benefits of working alongside everybody. So community pharmacy, the community pharmacists, Community Pharmacy Derbyshire, personally, who I've worked alongside with, ICBs and the other trusts.
Yes,
it's really useful for kind of shared learning, best practice. So really appreciate everybody's input.
Brilliant. Thank you, Lauren. Stacey?
I'd probably just like to mirror what Lauren said, because she said it so eloquently.
It is that example. It's a prime example of neighbourhood health. I'll put my teeth in again, in action. We're all supposed to be working together collaboratively for the benefit of the patient, and this is an excellent example. And as you say, getting together, it would be great to get together with you again, perhaps in 6 months' time, to see where we are, to if there's been any changes. I can see Mike nodding, and we will absolutely do that. And I think if we can open up those communications channels through this podcast, then that will be super. I'm going to come finally to Mike because he's popped back up again.
Yeah, thank you. Well, I think the thing I haven't mentioned up until now is I just wanted to say a huge thank you to Stacey and Lauren and the teams in both of these trusts, because this does not happen around England.
No.
There are a lot of locations, Birmingham being one of them, and you can imagine the size of the Birmingham hospitals. Birmingham don't do the discharge medicine service at all, or very little. So around England, we're working with great trusts who are doing a great job, who are discharging to community pharmacies, and I guess we owe it to the trusts because of the faith and the trust that they have in us to actually play our part.
Yes. Yeah, absolutely, Mike. Well said. Well said.
Thanks, Mike.
Yeah. And we would, as I say, very much like to revisit this, everybody, if we can at some point. And I will echo what Mike's just said. Very, very much appreciate your input and thank you for everything. And let's keep talking and let's keep improving wherever we can. So, yeah, thank you, everybody. I'm going to move on and I'm going to sign off. And we hopefully, again, we will chat again in 6 months' time. So we will make contractors aware of this. And as we've said, any questions for Stacey or Lauren and Mike at the end of this, we'll put details on. And you know, we'll get in touch. Feel free to get in touch with any questions you might have. or even any suggestions. You know, if you think something can be done better or something's not working, let us know, and we'll fix it. So thank you everybody for listening, and thank you for your time, everybody. Again, it's great to hear from you, and we'll hear and speak and listen with everybody again soon.
Thank you.
Thank you, Lauren. Thanks, Stacey.
Thank you.
Thank you.
Bye.
Bye.
Bye.